Julia Grabsa will explain how to assess the right ventricle and pulmonary hypertension. She will show us the multiple views that we have to use to assess the right ventricular morphology, and she will show us all the parameters that we have to measure, especially to assess the pulmonary hypertension severity.
In the assessment of a patient with pulmonary hypertension, the first view that we will get will be the parasternal long axis view, and we will place the probe on the fourth intercostal space. So from the parasternal long axis view, it is important to detect the right ventricular size and shape and the contractility of the chamber. It is also important to associate this with the left ventricular cavity. As we know, the right ventricle has 1/3 the size of the left ventricle in healthy volunteers, and also it has 1/6 of the mass of the left ventricle. So in a patient with pulmonary hypertension, the right ventricle will dilate, hypertrophy, and the contractility will be reduced. As you may see, on our patient, the right ventricle is dilated and hypertrophied, and there is also an abnormal septal motion of the interventricular septum, and that reflects the pressure overload of the right ventricle. It is important when we assess the dimensions of the left ventricle to know that we should not include the moderator band. The moderator band is a muscle which transverses the right ventricle close to the apex, and it is hypertrophied in patients with pulmonary hypertension. Furthermore, due to the pressure overload of the right ventricle onto the left ventricle, the size of the left ventricle will be reduced. It is important from the same view to assess also the size of the left atrium, and as we know, the gold standard for the left atrial assessment is left atrial volume. Then I'm tilting my probe towards the right leg of the patient, and the next view to obtain will be the parasternal right ventricular inflow view. So from this view, we will be able to assess the right ventricular cavity, its dilatation, and if it is again hypertrophied, and if it does not contract well, and also detect the tricuspid annulus, the tricuspid valve, and for example, in this occasion, the tricuspid annulus is dilated, and furthermore, to see the right atrium and if this chamber is dilated. The normal structure that we'll detect in this view will be the Eustachian valve. Then I will change position of my probe. So by rotating now the transducer 90 degrees to the right and towards the right shoulder of the patient, we will be able to see the parasternal right ventricular outflow tract view. So the first structure to detect will be the pulmonary valve, but the most important would be to have a non-axis view of the parasternal right ventricular outflow tract. This will be the view to show us the extent of the pulmonary artery and the two branches, the right and the left, and also the right ventricular outflow tract as well as the pulmonary valve. It is important view to exclude congenital abnormalities of the pulmonary valve, such as pulmonary valve stenosis, and also further down to exclude an absence of a pulmonary artery branch or any other congenital abnormalities. It is important to mention that the normal size of the pulmonary artery is almost equal to the aortic valve, and that's an easy way to assess its size. In patients with pulmonary hypertension, the pulmonary artery, as it's measured above the pulmonary valve, will exceed 3.5 centimeters from a healthy volunteer. So now rotating about 45 degrees, we will get the next view, which will be the parasternal short axis view at the level of the aortic valve. This is also important, first of all, to assess the aortic valve and if that's structurally normal, and to be able to see the cusp excursion. For example, on this occasion, the aortic valve is tricuspid, and as you may see, the right, the left, and the non-coronary cusps have a normal excursion. It is important that we will see the right ventricular cavity and the tricuspid valve, and also the right atrium. And furthermore, we are able to detect the interatrial septum between the right atrium and the left atrium, and to detect its motion and if that's abnormal or not. It might reveal a cause of volume overload, such as atrial septal defect or a PFO, especially when we apply color Doppler at a later stage. Then by rotating furthermore our transducer towards to the right, we will get the parasternal short axis view at the level of the mitral valve. And this is the first view to start our parasternal short axis assessment of the left ventricle together with the right ventricle. So from the parasternal short axis view of the mitral valve, initially we judged if the mitral valve is structurally abnormal, and in fact here we are able to see the anterior and the posterior leaflets, and that is a structurally normal valve. But the most important is to assess the shape of the left ventricle, and further important is to assess whether it's pressure or volume overload. If we move our transducer one intercostal space higher, then we will get the parasternal short axis view of the papillary muscles. The view of the parasternal short axis at the level of papillary muscle is important to differentiate the pressure and volume overload, and we use an index which is called the left ventricular eccentricity index. That is important because then in healthy volunteers the left ventricle is circular in shape. The eccentricity index is measured by the ratio in end diastole and end systole, and it is the ratio of the dimension which is parallel to the septum versus the dimension which is perpendicular to the septum. For example, on this occasion in end diastole, this is the ratio parallel to the septum, and then the ratio perpendicular to the septum. And this ratio, the one versus to the other, if it is more than one, then that means that it's either volume or pressure overload. In end systole, if we do the same and get the dimension parallel to the septum versus the dimension perpendicular to the septum, and the ratio, as we may see, it's greater than 1, and that indicates pressure overload right ventricle. It is important to say that in patients with pure volume overload, the eccentricity index will be greater than 1 only in end diastole, when in patients with pressure overload, the eccentricity index will be greater than 1 both in end systole and end diastole. And it is very important to differentiate between pressure and volume overload. I'm changing the probe and I'm going to the cardiac apex. So the next view to obtain will be the forapical chamber view. That's very important because we have the 4 major chambers of the heart, and as we may see, the left ventricle, the right atrium, and the left atrium, as well as the mitral valve and the tricuspid valve. Here it's very important to assess all the extent of the left ventricle and its size and its function. And just to say that it's important to assess the systolic and the diastolic function of the left ventricle. In patients with pulmonary hypertension, it is important to have a detailed examination of the left ventricle from the 5-chamber view, from the 2-chamber view, and also from the 3-apical chamber view in order to assess its systolic function. Furthermore, with the use of Doppler, it is important to assess the mitral inflow and to get E to A ratio, as well as to use the TDI, tissue Doppler imaging, from the septal wall and the lateral wall and assess the degree of diastolic dysfunction. Don't forget that many patients with pulmonary hypertension will have post-capillary pulmonary hypertension, therefore we need to exclude a significant degree of left ventricular diastolic dysfunction. So, by moving the transducer more lateral and tilting towards the patient, we will have a more focused view of the right ventricular cavity. It is very important in patients with pulmonary hypertension that we should include the right ventricular apex into our view, and that's a major disadvantage if we do not include the apex. As we know, the right ventricle will be hypertrophied and dilated, therefore we get a more lateral view in order to include all the right ventricular body. This is the view that we will assess all the extent of the right ventricle and the tricuspid annulus, as well as the right atrium. For example, on our patient, as you may see, the right ventricular free wall is significantly hypertrophied, and the right atrium is significantly dilated, as well as the tricuspid annulus, which is dilated and will cause functional tricuspid regurgitation. This is the view that we will get the right atrial volume index. And the right atrial dilatation is very important for the patient's prognosis and follow-up, as we know that it's a bad prognostic marker. So it is important to measure the right atrial volume from the forapical chamber view, and in order to do that, we stop the sequence at end systole, and then we trace subsequently the right atrium and then we modify the length to be more central, and the machine will get the method of Simpsons to calculate the right atrial volume. It is important to mention that in healthy volunteers, the normal right atrial volume is 34 mL per meter square in men, while 28 mL in meters per meter square in women. From the focused forapical chamber view on the right ventricle, we will apply M mode onto the right ventricular free wall close to the tricuspid annulus. And the measurement that we will take will be the tricuspid annular plane systolic exertion, or as called TAPSE. TAPSE is very important because it demonstrates the longitudinal function of the right ventricle, and it's measured from the descending to the ascending waveform of the tricuspid annular exertion. We should mention that TAPSE is a volume overloaded dependent measurement, and that means that when we have a volume overload effect, such as an ASD or tricuspid regurgitation or even pulmonary regurgitation, then the TAPSE might exceed even 30 millimeters, while as we know the normal cutoff value is less than 20 millimeters. In patients with pressure and volume overload, the TAPSE might be pseudonormalized, and this is something that we should bear in mind when we scan patients with pulmonary hypertension. From this view of the forapical chamber view, focused on the right ventricle, the next measurement that we will take will be with tissue Doppler imaging. And we will apply tissue Doppler imaging on the right ventricular free wall, and most important, we will apply the pulse wave Doppler almost 1 centimeter above the tricuspid annulus. This is the waveform that we will get with tissue Doppler imaging. And this is very important because it gives us a lot of information and measurements from the cardiac cycle. In fact, we will get from this waveform, we will be able to detect the isovolumic contraction time of the right ventricle, the ejection time of the right ventricle, the isovolumic relaxation time, which will be prolonged in patients with pulmonary hypertension, and then the E' and A' waves. It's also important to mention that the peak velocity is called systolic S-wave velocity, and it's prognostic in patients with pulmonary hypertension. The systolic S-wave velocity has a normal cutoff value less than 11.5 centimeters per second. And as you may see, in our patient, the systolic S-wave velocity is 12 centimeters per second, which means borderline normal. Even though we should bear in mind that TDI is influenced in patients with atrial fibrillation, and that's why we should take 3 consecutive measurements when we have patients with arrhythmias. Just furthermore to mention that the isovolumic relaxation time is important in patients with pulmonary hypertension, and it prolongs when a patient has pressure or volume overload of the right ventricle. The normal cutoff value is that it's less than 110 milliseconds, and when it's prolonged, that means that the patient has signs for pulmonary hypertension. From the same view of the forapical chamber, if we apply color Doppler, we will be able to detect the severity of the tricuspid regurgitation. And as you may see, the turbulence across the tricuspid annulus will cause functional tricuspid regurgitation. The assessment of the severity of tricuspid regurgitation is performed according to the European guidelines. And here we could say that the tricuspid regurgitation is mild to moderate in severity. Note that it is very important the severity of tricuspid regurgitation is prognostic for patients with pulmonary hypertension, while the velocity of the tricuspid regurgitation is not prognostic. In order to assess the right ventricular systolic pressure, we get the continuous wave Doppler across the tricuspid regurgitation. And we will be able to detect the waveform of tricuspid regurgitation, and its peak is the maximum velocity of tricuspid regurgitation. In patients who do not have pulmonary stenosis and do not have massive tricuspid regurgitation, the Bernoulli equation will be applied in order to get the right ventricular systolic pressure. And the Bernoulli equation means that we will get the maximum velocity. This will be squared and multiplied to 4, and we will get the peak gradient, which on our patient is 62 millimeters per mercury, and then we will add the right atrial pressure. This will give us the right ventricular systolic pressure. It is important to mention that patients with pulmonary hypertension at an end stage, due to significant dilatation of the tricuspid annulus, will have massive tricuspid regurgitation, or in few countries is called free-flow tricuspid regurgitation. In that occasion, the Bernoulli equation cannot be applied, and therefore we have to use other parameters to assess the patient with two-dimensional echocardiography. Furthermore, it is important to say that according to the literature, the tricuspid regurgitant velocity may be influenced by the body surface area and age. So we should always bear in mind that the patient's right ventricular systolic velocity might change according to his body size and the age. So then we change the probe and we go back to the parasternal short axis view of the right ventricular outflow tract. And from this view, with the color Doppler, we will be able to exclude significant pulmonary regurgitation. If we have pulmonary regurgitation, in order to assess the pulmonary end diastolic pressure, we will use again the Bernoulli equation, this time with the pulmonary regurgitant velocity. With the color Doppler, and if we apply the pulse wave Doppler onto the pulmonary valve, we will get this signal. And the significant measurement is the right ventricular outflow tract acceleration time, which is the measurement from the closure of the pulmonary valve to the maximal systolic velocity. In healthy volunteers, the right ventricular outflow tract acceleration time is prolonged, and it's usually more than 140 milliseconds, while in patients with pulmonary hypertension, it will be reduced, demonstrating significant dysfunction of the right ventricle, and it's usually less than 105 milliseconds. Furthermore, it is important to say that in patients with pulmonary hypertension, the literature has shown that the pulmonary systolic notch that you might see on this waveform is associated with increased pulmonary vascular resistance. By positioning the transducer at the subcostal space, we will be able to get the subcostal view. And this is very important because it demonstrates all the 4 chambers, and we will be able to assess the interatrial septum and to see whether the patient has any evidence of atrial septal defect or a patent foramen ovale. Furthermore, most important, we will assess the continuation of the right atrium to the inferior vena cava. A significant measurement will be the right atrial pressure, and it is important because it will also add to the maximum gradient to assess the right ventricular systolic pressure of the patient. In order to assess the right atrial pressure, we use the diameter of the inferior vena cava and the respiratory collapse, and we might need to tell the patient to sniff in order to see whether there is any respiratory collapse of the inferior vena cava. When the inferior vena cava is dilated and there is no respiratory collapse, then the right atrial pressure might be equal to 20 millimeters per mercury. Furthermore, when the hepatic veins are dilated from the subcostal view, then the right atrial pressure further increases and it might reach 25 millimeters per mercury. As a conclusion, when assessing a patient with pulmonary hypertension, it is important to get the full protocol to assess the right ventricular cavity and to assess the tricuspid regurgitant severity. Don't forget that the severity of tricuspid regurgitation is significantly different when compared to the velocity of tricuspid regurgitation, and the severity of tricuspid regurgitation is prognostic for our patients. Furthermore, do not forget that one index is not enough to exclude or to assess pulmonary hypertension. We need to use the full protocol and all our measurements to have an overall view for the right ventricular cavities.
Lessons to be learned from this examination is that we have to take multiple views, multiple parameters. We have to look at the right ventricle, of course, but also to secondary cause of pulmonary hypertension. And finally, the key message is that we have not to mistake that the peak velocity of the tricuspid regurgitation does not necessarily reflect the severity of the tricuspid regurgitation.